So our speaker today is Julie Gray, who graduated with her Doctor of Pharmacy from the University of Minnesota, Twin Cities in May of 2022. She is in her first year of pharmacy residency at the University of Utah Health, and she'll be staying on to complete a PGY2 in infectious diseases with plans to become a board-certified infectious diseases pharmacist. She currently staffs on the internal medicine unit and has an interest in immunocompromised infectious diseases. So thank you, Julie.
Great. Thank you so much for that introduction, Stacy. And thank you all for coming to the CE addressing the misconceptions, IV versus oral antibiotics in invasive infections. Quick disclosure, there are no financial conflicts of interest for myself, my CE mentors, and all antibiotic uses discussed in this presentation are considered off-label indications. Here's a list of abbreviations I'll be using throughout the presentations that are available to you to refer back to. And to start off with our learning objectives for pharmacists first, the first one is to analyze the literature surrounding the use of oral agents in the treatment of invasive infections. Second is to describe the bioavailability, penetration, and adverse effects of preferred oral antibiotics. And third, evaluate a treatment and monitoring regimen for patients with invasive infections. For technicians, the first objective is to identify oral antibiotics that are appropriate for treating invasive infections. Secondly, recognize common adverse effects associated with preferred oral antibiotics for invasive infections. And lastly, differentiate between infectious indications for which oral antibiotics may be appropriate. A little bit of background on this topic. For many years, it was assumed that IV antibiotics are necessary to successfully treat invasive infections such as osteomyelitis, endocarditis, and bacteremia. This presumption stems from uncontrolled case series from the 1940s and 50s and the limited bioavailability of the few oral antibiotics that were available at that time. Think like erythromycin, tetracycline, things like that. There were few well-designed studies comparing the efficacy and safety of oral antibiotics for these infections until more recently. And the necessity of IV-only therapy for these diseases has kind of been ingrained in clinical and professional society guidelines. What are some risks of IV therapy? So IV therapy may result in some harmful complications such as line-related infections, thrombophlebitis, which is a blood clot that can occur from an IV line, extravasation when the drug leaks out of the vein into the surrounding tissues, can result in a longer hospital length of stay, and increased direct and indirect drug costs, including the cost of the drug itself, the need for home health on discharge, and the equipment to administer the drugs. Some benefits of oral therapy. Oral therapy does mitigate those risks that I previously mentioned that are associated with IV treatment. It's usually more affordable for patients and can result in a shorter hospital length of stay and generally more convenient to patients and the healthcare system. Now I'll be discussing some considerations for some of the preferred oral antibiotics that you'll commonly see throughout this presentation. This is not an all-inclusive list. First, let's go through some characteristics of some of the preferred oral antibiotics used in treating invasive infections. We have amoxicillin and amoxicillin clavulanate, which have moderate bioavailabilities. Frequent dosing, as you can see here, at least 3 times daily. Amoxicillin does have good data in infective endocarditis, while amoxicillin clavulanate has data in diabetic foot infections. There are no significant drug interactions with these two drugs, and the most common adverse effect is stomach upset with amoxicillin and other penicillins, which can be usually mitigated by taking with food. Ciprofloxacin has good bioavailability, a twice-daily dosing, and strong data in bone and joint infections. The most significant drug-drug interaction is with polyvalent cations, such as like magnesium, calcium, and iron in food and in supplements. As we know, fluoroquinolones do have many potential adverse effects, including QT prolongation, aortic aneurysm, tendinitis, C. diff infections, and some CNS effects are possible. Levofloxacin is very similar to ciprofloxacin. However, it does have a higher bioavailability and only once daily dosing. Clindamycin has good bioavailability, dosed 3 times a day, and does have some data in bone and joint infections. There are no significant drug-drug interactions, and the most common adverse effects are GI upset and C. diff infections. Next, linezolid has 100% bioavailability, is dosed only twice daily, and does have strong clinical data in both bone and joint infections and infective endocarditis. There are many drug-drug interactions, most notably with the serotonergic agents like sertraline, and some significant adverse effects are thrombocytopenia, which is low platelets, anemia, low red blood cells, myelosuppression, also it's decreased bone marrow activity, and neuropathies. But typically, these more severe adverse effects are seen with the longer durations of treatment, so over more than 2 weeks of treatment. Next, we have trimethoprim sulfamethoxazole, which overall has good bioavailability. The dosing is weight-based, so that's something to note, and that's on the trimethoprim component, which some people do tend to get confused. That's 3 times daily, and it does have strong data in bone and joint infections. Most commonly has drug interactions with nephrotoxic agents and drugs that also can increase potassium levels. So kind of going with that, adverse effects include elevated potassium levels, acute kidney injury, anemia, leukopenia, or low white blood cell count, and also low platelets. Lastly, we have doxycycline, which has very good bioavailability. It's dosed twice daily. It does have some data on in vitro bone penetration as well. Drug-drug interactions are similar to the fluoroquinolones, and some unique adverse effects such as sun sensitivity, esophageal irritation, and skin discoloration. So when we're kind of assessing bioavailability, there's kind of some categories, and of note when categorizing bioavailability as high, moderate, and low, different sources may have some slightly different cutoffs. So you may hear a recommendation for a highly bioavailable antibiotic and see, let's say, trimethoprim sulfamethoxazole recommended, for example, which you will hear throughout this presentation as well. To summarize bioavailability, clindamycin, doxycycline, levofloxacin, and linezolid all have high bioavailability. Aminopenicillins, trimethoprim sulfamethoxazole, and ciprofloxacin have moderate bioavailability. And lastly, cephalosporins generally have low bioavailability. Considerations when thinking of patients who may be eligible for oral therapy, whether they're clinically stable, if they have gastrointestinal or GI abnormalities which may limit absorption, such as like a Roux-en-Y gastric bypass, chronic diarrhea, and inflammatory bowel disease. These conditions are not contraindications for oral therapy, but things that should be considered on a case-by-case basis. There is also limited data with oral treatment in patients who are morbidly obese with a BMI of greater than 40. It's important to use a highly bioavailable antibiotic, such as linezolid, fluoroquinolones, and doxycycline, that is active against the suspected or confirmed pathogen. Although it is also important to assess efficacy with clinical outcomes, not only bioavailability. It's something to keep in mind. It's necessary to assess compliance to an oral regimen. Some patient populations are less likely to be compliant with oral treatment and actually may be better candidates for IV therapy. In many cases, patients will have home health to give them their IV antibiotics, so you know they'll be getting their treatment regularly. Whereas when patients go home on oral regimens, there's no one there to help, make them accountable to take their medications as prescribed. Summarize, oral antibiotics are more convenient, cost-effective, and may decrease the hospital length of stay. We do have landmark trials, which I will go into later in this presentation, to provide insight into the use of oral therapy for invasive infections. And patient and drug selection really are the key to success for treatment. The first category of infections we'll be covering today is the bone and joint infections. Overall, management for bone and joint infections includes surgical source control when possible, and historically has been treated with a prolonged course of IV antibiotics, typically at least 6 weeks of therapy. We do have IDSA guidelines for native vertebral osteomyelitis, diabetic foot infections, which include diabetic foot osteomyelitis, and prosthetic joint infections. However, as you can see, these guidelines are not updated very frequently, so it's important to be familiar with the newer data coming from clinical trials. First, to kick off the bone and joint infections, we'll go through native vertebral osteomyelitis. Currently, the IDSA guidelines for native vertebral osteomyelitis recommend 6 weeks of IV or highly bioavailable oral antibiotics such as fluoroquinolones, linezolid, and metronidazole. They do not recommend oral beta-lactams for the first line of treatment for this indication. Generally, we see staph, enterococcus, pseudomonas, and gram-negative organisms as the most common pathogens that cause vertebral osteomyelitis. So the first trial in this section we'll be talking about is the antibiotic treatment for 6 weeks versus 12 weeks in patients with pyogenic vertebral osteomyelitis. The goal of this trial was to establish whether 6 weeks of antibiotic therapy was inferior to 12 weeks in patients with pyogenic vertebral osteomyelitis. It was an open-label, non-inferiority, randomized control trial, enrolled patients of 18 years of age or older with pyogenic vertebral osteomyelitis without vertebral implant. So in this trial, 359 participants were randomly assigned to receive 6 or 12 weeks of antibiotic treatment. In this trial, antibiotic regimens were not pre-specified. MRSA infections were included in both groups, and treatment failure was defined as death at 1 year or extending treatment by greater than 6 weeks. So the most common pathogens included in the trial reflect the most common pathogens we typically see in this type of infection, and the follow-up duration was 1 year. The primary endpoint, as we can see on the right-hand side in the results, was the proportion of patients classified as cured at 1 year. And the outcomes between the two groups were incredibly similar. About 91% of patients in both the 6 and 12-week groups met the criteria for clinical cure. The difference between the groups showed non-inferiority of the 6-week regimen when compared to the 12-week regimen, and adverse events were the same in both groups. Overall, about half of the patients received IV antibiotics for about 2 weeks in both groups, with the most common oral antibiotics being fluoroquinolones and aminopenicillins. The average duration of initial IV treatment, again, was about at that 2-week mark in both groups before switching to a completely oral regimen for the remaining duration of treatment. So the trial concluded that there is no difference in cure between the two treatment durations with a limited initial IV antibiotic duration. I chose to discuss this trial because it enforces that switching to oral agents for a majority of the total treatment duration is effective. Next trial is the oral versus standard antimicrobial treatment for pyogenic native vertebral osteomyelitis. The aim of this study is to assess whether there's an association between the administration of an entirely oral antibiotic therapy and the clinical outcome of native vertebral osteomyelitis. It was a single-center retrospective observational study including 249 participants with pyogenic native vertebral osteomyelitis over a 10-year period from 2008 to 2018. These participants did not have a history of previous vertebral surgery or infection. And this really was one of the first studies to focus on initial oral treatment rather than a switch therapy, switching from initial IV to eventually oral. The oral treatment group included patients treated exclusively with an oral antimicrobial agent. They could receive less than 24 hours of IV treatment, but no more than that. Standard treatment was defined as an initial IV therapy for greater than 24 hours, followed by what they called a feasible oral switch. So overall, 98 patients were treated with the IV route of administration for the whole treatment duration, whereas 105 participants initially received IV antimicrobial regimen for a median duration of 22 days in that IV switch group, followed then by oral therapy. The median treatment duration in both groups was greater than 12 weeks, so longer than what we would typically see here in the U.S. In this trial, antibiotic regimens were not pre-specified and up to the treating team. They did exclude multi-drug resistant organisms in their outcomes in both groups. Treatment failure was defined as no improvement or progression of infection while on treatment. And again, the pathogens were very similar to what we would expect in this type of infection, and follow-up was 1 year. The primary endpoint was clinical cure, defined as sustained absence of fever and normal inflammatory markers, plus the remission of pain and survival at 12 months after the end of the first treatment course. Results on the right show that 94.4% of the patients in the oral treatment group experienced clinical cure compared to about 87% in the IV switch group. And this was shown to there wasn't a statistical significant difference between the two groups. Adverse events were, again, similar between the two groups, and the most common adverse events being tendinopathy, GI intolerance, and skin rash. And no difference between those groups. Overall, the most common oral antibiotics used were fluoroquinolones with or without rifampin, minocycline with or without rifampin, and then some others mixed in there. The trial concluded that an entirely oral treatment regimen may be as effective as IV treatment in some patients with native vertebral osteomyelitis. So this trial was a good first look at completely oral regimens for native vertebral osteomyelitis. Next, we'll be looking into the literature for treating diabetic foot infections. The most recent IDSA guidelines for diabetic foot infections recommend IV therapy for all severe and some moderate diabetic foot infections, at least initially, and this initial period isn't really well defined in the guidelines. It's recommended to switch to a highly bioavailable oral agent when the patient is clinically stable and culture results are available. The first trial is the 3 weeks versus 6 weeks of antibiotic therapy for diabetic foot osteomyelitis. And the goal was to determine whether in patients who underwent surgical debridement, a short 3-week treatment duration compared to a longer 6-week duration, whether that was non-inferior for clinical remission and adverse events. It was a prospective, randomized, non-inferiority pilot trial with 93 patients who were diagnosed with diabetes according to the American Diabetes Association criteria, categorized as moderate or severe infections based on the IDSA diabetic foot infection classifications. They had to have received appropriate surgical intervention and did not have an implanted device present. So participants were randomized 1-to-1 who had diabetic foot osteomyelitis after surgical debridement to either a 3-week or a 6-week course of antibiotic therapy. In this trial, antibiotic regimens were pre-specified. They did exclude multi-drug resistant organisms. Treatment failure was defined as recurrence or persistence of infection at the same site, at least one of the same pathogens for polymicrobial infections. And the most common pathogens seen in the trial were staph, strep, and gram-negative organisms. The follow-up was a minimum of 2 months, which is pretty short. However, overall, the median of 11 months of active follow-up was done. The primary outcome was clinical remission after a minimum of 2 months of follow-up after the end of therapy. Results on the right show that 44 participants, or 84% in the 3-week group, and 73% in the 6-week group had remission after at least 2 months after treatment. There was no significant difference between these two groups. The graph on the right shows the secondary outcomes, so there was no significant difference between the two groups for microbiological recurrence, partial amputation, or wound healing. Adverse events were also similar between the two groups. And overall, the median duration of IV antibiotics was only 2 days, and it was actually 1 day in the 3-week group and 3 days of IV therapy in the 6-week group. Therefore, a large majority of the treatment was done with oral antibiotics. There was no protocol for switching from IV to oral therapy. It was at the discretion of the treating physician. The most common orals used were amoxicillin clavulanate, levofloxacin, clindamycin, trimethoprim, sulfamethoxazole, and doxycycline. The trial concluded that a 3-week antibiotic course was non-inferior when compared to a 6-week course after debridement for diabetic foot osteomyelitis. This trial really did show that the treatment with a very limited initial IV course before switching to oral treatment may be effective for this indication. Remission rates with only using 2 days of IV treatment prior to orals in this study are fairly comparable to other studies that use IV treatment for longer. This slide just briefly summarizes two trials done in France that looked at the treatment of diabetic foot osteomyelitis without surgical intervention, whereas the previous trial I just discussed did require surgical intervention for inclusion. Both trials here included patients who were treated with an entirely oral antibiotic regimen and those who received a limited duration of IV antibiotics prior to switching to orals. So the purpose of the first trial here was to identify the criteria predictive of remission in non-surgical treatment of diabetic foot osteomyelitis. The intervention was to treat with antibiotics only using fluoroquinolones with or without rifampin or another combination of antibiotics. Looking at the participants who had treatment failure, about 22% received IV antibiotics for the first week, and about 37% of those in the remission group received IV treatment for the first week. So what to take away from this trial essentially is that antibiotic treatment without surgical intervention was given entirely oral or initial IV treatment for less than or equal to 7 days. And the study concluded that IV therapy for the first week of treatment was not significantly associated with remission compared to those who received no or a very short course of IV treatment. The purpose of the second trial was to compare the effectiveness of the 6 versus 12 weeks of antibiotic therapy in patients with diabetic foot osteomyelitis treated non-surgically. The intervention was antibiotics without surgical intervention with specific antibiotics given based on culture results. Results showed that remission between the 6-week and 12-week groups were similar. However, there were fewer GI events seen in those who were only treated for 6 weeks compared to the 12-week group, and that was actually statistically significant. Overall, the takeaways from this trial are that the 6 versus 12-week treatment durations resulted in similar outcomes, and the antibiotics were given either entirely oral or with an initial short course of 5 to 7 days of IV treatment before switching to orals. The study concluded that 6 weeks of a predominantly oral regimen may be sufficient in patients with non-surgical diabetic foot osteomyelitis. So the last type of orthopedic infection I'll be covering are the prosthetic joint infections. The IDSA guidelines for prosthetic joint infections separate the recommendation based on the type of surgical intervention. First, at the top, if the prosthesis is retained after surgery or if the replacement is done in the same surgery, they recommend an initial course of IV treatment, then switching to an oral antibiotic, and that's for staph infections. For prosthetic joint infections due to other organisms, they recommend either IV or oral therapy is appropriate. For a two-stage exchange in the bottom half, where the first surgery is to take out the prosthetic and clean out the infection and treat with antibiotics, and at a later date the prosthetic is replaced, IV or a highly bioavailable oral therapy is recommended. Again, the IDSA preferred agents are listed on the right, and as you may notice, these are all considered, highly bioavailable or at least moderately bioavailable medications. So the first trial on this topic was the DePito trial. The goal of this trial was to determine whether a shorter or 6-week treatment duration, how that compared to a longer 12-week duration, and whether that was non-inferior for clinical remission and adverse events. It was an open-label, randomized, controlled, non-inferiority trial that included 404 participants with a prosthetic joint infection of the hip or the knee, managed with appropriate surgical intervention. They were randomized 1-to-1 to receive either antibiotic treatment for 6 or 12 weeks. In this trial, antibiotic regimens were not pre-specified. Multi-drug resistant organisms were actually included in both groups, and treatment failure was defined in 3 categories as persistent or new infection or probable treatment failure, and the most common pathogens were staph, strep, and gram-negative organisms. This trial had a little bit of a longer follow-up. It was 2 years. Primary outcome was persistent infection within 2 years after completion of antibiotic therapy. And on the right-hand side, the results showed that there was no difference in outcomes between the treatment groups for treatment failure due to a new infection or probable treatment failure. Persistent infection occurred in about 18% of participants, or N of 35 in the 6-week group, and about 9% in the 12-week group. And this result, non-inferiority, was not shown for this outcome. Adverse events in the two groups were very similar. Overall, patients included in this trial received IV therapy for a median duration of 9 days, and that was similar between the two groups. The most common oral antibiotics were fluoroquinolones, clindamycin, and amoxicillin clavulanate. Ultimately, the trial concluded that a 6-week antibiotic course is not non-inferior to a 12-week course for the treatment of prosthetic joint infections, but it did show, for the purpose of the presentation, that a limited initial IV course of a total of 12-week treatment duration may be effective. This next trial's goal was to examine 1-year and 2-year outcomes of selective uses of oral antibiotics for orthopedic infections. It was a single-center retrospective analysis of 40 patients over a 6-month period for the first episode of surgically managed osteomyelitis, native joint septic arthritis, prosthetic joint infections, or another type of musculoskeletal hardware infection, who did receive surgical interventions and more than 2 weeks of antimicrobial treatment. Participants were either in the oral group, which were those who were treated with an initial course of IV antibiotics and then switched to oral, or they were in the IV group, which were treated with IV antibiotics for the full duration. So they did spell out kind of their criteria for who were eligible to switch to oral therapy, and that was, it had to be the first episode of infection to the affected anatomic site, the identification of a bacterial pathogen susceptible to one or more highly bioavailable antibiotics, no concern from providers about the patient's ability to adhere to oral antibiotic therapy, no vertebral infection, and no concurrent infection that required IV therapy. So that was the criteria for those who were eligible to switch to oral therapy. In this trial, the antibiotic regimens were not pre-specified. Multi-drug resistant organisms were included in both groups. Treatment failure was defined as death, unplanned surgery, or unplanned use of suppressive antibiotics. The most common pathogens were typical for what we see in bone and joint infections, and the follow-up again was 2 years. On the right, the primary outcome was treatment failure, which was seen in 0 of the 23 patients in the oral switch group and 6 of the 17 in the IV-only group. Adverse events were similar between the two groups. So overall, there were no significant differences in the characteristics of the switch group compared to the IV group in respect to the comorbidities, age, sex, or BMI. But they did not specify the types of infections between the groups if one was, heavier with a different type of infection. Overall, the most common types of infection were late and early prosthetic joint infections, where late was defined as greater than 90 days from surgery, and early was defined as less than 90 days from surgery. And then it goes down to other hardware infections, osteomyelitis, and lastly, septic arthritis was the least common type. Overall, in the oral switch group for prosthetic joint infections specifically, 10 days was the mean time to switch from initial IV therapy to oral. The most common oral antibiotics used in the oral switch group were amoxicillin clavulanate, trimethoprim sulfamethoxazole, and levofloxacin. The trial concluded that their criteria used to identify patients who would be successful at switching to oral antibiotics was effective. And looking at how there were no reported primary outcomes in the oral group, those differences in the outcomes could be due to the recurrent infections not being included in the oral group, but only included in the IV group. So that could also lead to kind of the differences in outcomes as well. So something to keep in mind when looking at this trial. And saving the best for last here, the OVIVA trial is really our main landmark trial for the assessment of oral treatment in bone and joint infections. The purpose was to investigate whether oral antibiotic therapy is non-inferior to IV antibiotic therapy for bone and joint infections. It was a multi-center parallel group randomized open-label trial which included just over 1,000 participants with acute or chronic bone and joint infections, native vertebral osteomyelitis, or native or prosthetic joint infections. They were randomized 1-to-1 within 7 days after surgery or treatment of the infection without surgical intervention to receive either IV or oral antibiotics to complete at least 6 weeks of therapy. In this trial, antibiotic regimens were not pre-specified. MRSA was included in both groups. Treatment failure was defined as the presence of at least one clinical, microbiologic, or histologic criteria, and the most common pathogens, again, were very typical for what we see in these types of infections. The follow-up was 1 year. The primary outcome of treatment failure occurred in 74, or about 14% of patients in the IV group, and 67, or about 13% in the oral group in the intention to treat population, and that did meet non-inferiority criteria. Adverse events were seen in 27 and 26% in the oral and IV groups, respectively, and early discontinuation of therapy was more common in the IV group than the oral group. Overall, the median hospital length of stay was actually 14 days in the oral group and 11 days in the IV group, which was surprising because it was hypothesized that treatment with oral antibiotics may lead to a shorter length of stay. However, the outcome was statistically significant for a longer duration of stay with the oral antibiotics here. Most common orals that were used were fluoroquinolones, penicillins, macrolides, and doxycycline. This landmark trial really concluded that the oral antibiotic therapy was non-inferior to IV antibiotic therapy for complex orthopedic infections when treated for at least 6 weeks. This slide is just to kind of summarize the antibiotics recommended in different bone and joint infections based on the available data that we have. Again, this is not an all-inclusive list of the oral options. For the treatment of bone and joint infections, most data really is in osteomyelitis and prosthetic joint infections. The optimal time to start orals or to switch after a short initial IV course really hasn't been well established. Excuse me. We do have data and guidelines to support oral treatment when the patient is clinically stable. In these types of infections, the OVIVA trial really is our main landmark trial for our bone and joint infections. Moving on from bone and joint infections, dive into infective endocarditis. Endocarditis has a high mortality rate, which ranges between 25 and 40%, and it differs depending on whether it's left-sided or right-sided. It's the fourth most common life-threatening infection after sepsis, pneumonia, and intra-abdominal abscess. Left-sided endocarditis is really the most common, accounting for 90 to 95% of cases, whereas right-sided is more associated with our IV drug use, cardiac devices, and catheters. Left-sided has worse outcomes generally than right-sided. Our infective endocarditis guidelines recommend long-term IV therapy, generally between 2. Most data is with gram-positive infections, which is what I'll be focusing on in this section. AHA infective endocarditis guidelines are separated by organism and recommends IV treatment for most patients. However, they do include it oral as an option in patients for whom IV therapy is problematic, and they use data from the 1996 and 1989 studies, such as for those who use IV drugs. One of those studies that they cite in the guidelines is the oral antibiotic treatment of right-sided staph endocarditis and injection drug. The purpose of this trial was to compare efficacy and safety of inpatient oral antibiotic treatment versus standard IV antibiotic treatment for right-sided staph endocarditis in injection drug users. This study was conducted to provide some guidance on using oral treatment in patient populations where IV treatment may not be an option. It was a prospective, randomized, non-blinded trial with 85 participants who were febrile injection drug users assigned to begin 4 weeks of oral or IV treatment on admission. And this was before the blood culture results were available. In this trial, antibiotic regimens were pre-specified to receive either ciprofloxacin and rifampin in the oral group, and then in the IV group, it was oxacillin or vancomycin. Fluoroquinolone resistance and MRSA infections were included only in the IV group, and treatment failure was defined as the development of any of the following, which was left-sided endocarditis, heart block of any degree, congestive heart failure, respiratory failure requiring mechanical ventilation, hypotension, sustained or recurrent bacteremia after 10 days of treatment or at an outpatient follow-up, metastatic infection, including meningitis or osteomyelitis caused by the same organism, or death. Only staph infections, as you can tell by the title of this trial, were included, and the follow-up really was only 1 month, so it was a very short-term follow-up. Primary outcome was blood test of cure, which was reported only by those who completed antibiotic treatment, which occurred in 95% of those randomized to receive oral treatment and 88% in the IV treatment group. Blood test of cure were done at hospital days 34, 35, and after 6 and 7 days post-treatment. And then the trial concluded that for selected patients with right-sided staph endocarditis, oral ciprofloxacin plus rifampin is effective. Although it's an older study, it's really one of the first that we have to tackle the topic of oral treatment. And it's important to also consider that only including MRSA in the IV group could potentially impact outcomes due to the nature of that infection being more difficult to clear. And their primary outcome was really focused on the ability to clear the infection. The last trial we'll be looking at the POET trial, which is the main landmark trial for assessing oral antibiotic therapy in left-sided infective endocarditis, in contrast to the previous trial, which was right-sided endocarditis. The purpose of this trial was to determine whether a switch from IV to oral antibiotics, once the patient is in stable condition, would result in efficacy and safety similar to those who continued IV treatment. It was a randomized, non-inferiority, multi-center trial, which included 400 adults in stable condition who had endocarditis of the left side of the heart. Patients were treated with IV antibiotics and assigned to continue IV treatment or be switched to oral antibiotic treatment. In all patients, antibiotic treatment was administered for at least 10 days, and then, if feasible, patients in the oral treatment group were discharged to outpatient oral treatment. In the oral group, switch to orals were made when the patients had a satisfactory response to initial IDD treatment, and they define that as being afebrile for greater than 2 days, CRP of less than 25% of the peak level or just less than 20 milligrams per liter, and then leukocytes of less than 15 is satisfactory response. In this trial, antibiotic regimens were pre-specified, multi-drug resistant organisms were excluded, treatment failure was defined as participants in the oral group needing to switch to IV therapy, and pathogens included were strep, E. faecalis, Staph aureus, and coag-negative staph. Follow-up here was only 6 months. The primary outcome was composite of all-cause mortality, unplanned cardiac surgery, clinically evident embolic events, or relapse of bacteremia with the primary pathogen from randomization through the 6 months after the treatment was completed. The primary composite outcome occurred in 18 or 9% in the orally treated group and 24 or 12% in the IV group, which did meet non-inferiority criteria. Specifically, in the subsection of the primary outcome, there was all-cause mortality, and that's shown on the right-hand side, and that was lower in the oral group, whereas the other outcomes were similar between the two groups. Adverse effects from the antibiotics were also similar in the oral antibiotic regimens were mainly aminopenicillins plus another companion oral drug or linezolid combination therapy for coag-negative staph infection. It's very important to note that this trial was not done in the U.S., but it was done in Denmark, and there they have less staph resistance to penicillins and more adequate susceptibility testing than we have here in the U.S. So potentially more reasonable options for oral treatment of staph infective endocarditis here in the U.S. may be fluoroquinolones rather than amoxicillin for these reasons. The trial concluded that with endocarditis of the left side of the heart, for patients who were in stable condition, changing to oral antibiotics after at least 10 days of IV treatment was non-inferior to continued IV antibiotic treatment. For anyone who was disappointed with the short-term follow-up of that trial, thankfully the authors of POET did analyze long-term outcomes in their patients. Primary endpoint, which was the primary outcome of a composite of all-cause mortality, unplanned cardiac surgery, clinically evident embolic events or relapse of bacteremia with the primary pathogen. That was lower in the oral group compared to IV. However, they did assess that this difference is mainly due to lower incidence of death from any cause in the oral group. So they did conclude that there was no increased treatment failure in patients who transitioned to oral therapy compared to those who continued on IV treatment. On the horizon for infective endocarditis, research in this area, the rodeo trial, which will evaluate the use of oral switch levofloxacin and rifampin after 10 days of IV therapy for infective endocarditis, may offer support to the efficacy of fluoroquinolone plus rifampin strategy. Here, this trial, it really does kind of mirror the POET trial. The methods and outcomes are very similar, and this trial may offer a little bit more applicable research for us as far as using levofloxacin for those staph infections rather than an immunopenicillin, how the POET trial did. Here's a table to summarize potential oral regimens for infective endocarditis. It's important to note that staph species, again, are frequently resistant to penicillins in the U.S., and because of this, we don't have very adequate penicillin susceptibility that we would need to have in order to determine if we could use an oral penicillin for staph infective endocarditis, such as amoxicillin. So again, a fluoroquinolone may be a reasonable option for these patients due to its high susceptibility and bioavailability as seen in the first trial discussed in this. So for the treatment of infective endocarditis, starting with orals may be preferred in some patients, particularly those who use IV drugs. Similar to bone and joint infections, the optimal time for oral switch really has not been well established. And for endocarditis, the POET is our main landmark trial, and the Rodeo 1 and 2 trials will add much needed data in the future. All right, so now it is time to poll everywhere. We'll let everyone get kind of logged in quick. The first question asks, so it's a case, so DA is a 45-year-old male with definite left-sided native valve endocarditis due to MSSA. He's received 10 days of nafcillin continuous infusion and is clinically stable. His pertinent labs are listed below, kind of supporting that he's clinically stable. So the question is, according to which trial DA may be eligible to switch to oral therapy? So is that A, the Oviva trial, B, the Rodeo trial, C, the Cowboy trial, or D, the POET trial? Sorry. We might be plateauing here at our results. So D definitely seems to be the most popular answer, the POET trial. And that is correct. So first, starting with A, the Oviva trial is really our landmark trial for bone and joint infections. The Rodeo trial has not quite come out yet, so it isn't, kind of what we would cite for switching to orals yet. But, once that data does come out, it could become a very significant piece of information for us. The Cowboy trial is one that I made up, so it's not a relevant trial. And the POET trial is the correct answer, so that right now is our main landmark trial for infective endocarditis. Great work, thank you. All right, so same case. Oops, sorry. Might have just given that one away. What should DA's treatment and monitoring plan look like? We're at our peak responses. So it looks like most people chose C. So treatment with ciprofloxacin and rifampin, assessed for QTC prolongation and diarrhea. That is the correct answer. So the first option, A, treatment with amoxicillin and rifampin, monitor for long-term treatment failure because oral therapy is inferior to IV therapy. And that is not exactly what the data that I reviewed today has shown. So that A is not the correct answer, along with B for that same reason. D, treatment with Ceftonir, assessed for adherence and drug tolerance. Ceftonir is a very low bioavailable drug, so we wouldn't use it for infective endocarditis. So C, treatment with ciprofloxacin and rifampin, assessed for QTC prolongation and diarrhea, which are both potential adverse effects of ciprofloxacin. Great work. I'm hoping this. Okay. Which of the following is the correct description for levofloxacin? A, bioavailability about 60%, moderate bone penetration, adverse effects can be C. diff infections, tendinitis, CNS effects. B, bioavailability of 99%, good bone penetration, adverse events of C. diff infection, tendinitis, CNS effects. C, bioavailability 75%, good bone penetration, adverse events of ingrown toenails, QT prolongation, and serotonin syndrome. And D, bioavailability of 10%, poor bone penetration and adverse events of QT prolongation, aortic aneurysm, and tendinitis. Great. Everyone for your responses. So looks like most people chose B is the correct answer. So A is incorrect. The bioavailability is much higher for levofloxacin. It does have good bone penetration. Those adverse events are adverse events we may see with that medication. C is incorrect. It does not, mainly because of the bioavailability, and it does not cause ingrown toenails or serotonin syndrome. And D is not correct due to the bioavailability being much higher in levofloxacin. Those and the bone penetration is good. So, but those adverse events are ones that you can watch out. If everyone, just in case this shows the answer to, everyone close your eyes, please, as I switch over. I'm so sorry. Okay, which of the following is not an appropriate oral antibiotic for treating invasive infections? So, keyword here is oral antibiotics. So, which of the following would not be appropriate? Would it be trimethoprim, sulfamethoxazole, amoxicillin clavulanate, oral vancomycin, or levofloxacin? Right. So it looks like most people chose C, oral vancomycin. And that is correct. So for an oral antibiotic, A, B, and D were all ones we kind of discussed throughout the presentation that could be potential options for treating invasive infections. Oral vancomycin is used only in C. diff infections because it has incredibly poor oral bioavailability. So C is the correct answer.
And Julie, click on instructions instead of correctness, and then I think it'll not give your answer away. Like at the bottom. Oh.
I tried that the first time, and yeah. I must not been sad. I'm sorry.
That's okay.
Okay, so I think people are getting more confident either with my grid teaching or that I'm previewing the answers. But which of the following is a concern with amoxicillin? So which of the following could be a potential side effect of amoxicillin? A, stomach upset. B, CNS effects. C, cannot be taken with milk or multivitamins. Or D, it's dosed only once daily, so it's easier to forget. Right. So A looks like the overwhelming majority, and that is correct. So CNS effects and cannot be taken with milk or multivitamins really are more things that we can see with our fluoroquinolones, and also amoxicillin is dosed at least 3 times daily, and that actually makes it easier to forget. So A, stomach upset is definitely our most common adverse effect. All right. And last but not least, close your eyes. In which of the following disease states would it not be appropriate to consider oral antibiotic therapy? A, infective endocarditis, B, septic shock, C, a bone infection, or D, a joint infection? So which of the following would it not be appropriate to consider oral antibiotic therapy? Right. Oh, everyone agreed on this one. So septic shock, that is correct. So A, C, and D were all in infectious indications that I went through in the presentation, so I'm really glad no one chose those. So there are potential patient populations and scenarios where, switching to oral antibiotic therapy is very appropriate. And then septic shock, well, a patient is in septic shock. Right. So, through the end here, thank you everyone so much for all of your participation. And here is the code you have all been waiting for. What questions does everyone have?
In reviewing this data and literature, did you come across any mention of treating CNS infections with oral antibiotics?
That's a really good question. I did not. I was very focused on kind of those infectious indications, so it didn't come up in my search, but I think that is definitely something to look into for sure.
All right, Julie. And then we have a question in the chat. Did the authors speculate in the Oviva why the LOS was longer for oral therapy?
Not that I saw. There might have been some like commentary after or something like that where they maybe discussed that, but not that I can at least remember in searching through that. That's a great question as well. If anyone has any thoughts or insight, I guess.
All right. We have 2 more questions in the chat. Did the diabetic foot osteo trial, which included surgery, comment on whether proximal bone was evaluated by path smears to determine if margins were clean?
They didn't specifically say, like, that was also like a question I had because I feel like that's, something we want to make sure is happening. It just said like appropriate, from what I remember, like appropriate surgical intervention, I'm hoping. But they didn't like note whether or not like maybe in the outcomes, like if it said like, oh, these patients did not have like clean margins and these did. I didn't see any differentiation between those. At least I don't know about like clinically relevant. I think sometimes it's hard, even if it says the margins were clean, it's hard to also, say whether or not that's true. So I'm thinking that won't make too big of a difference, but if it like visually is not clean, I think, yeah, the outcomes likely won't be as good.
And any advice for convincing old school providers to switch from IV to oral antibiotics? Just cite these studies. Hopefully the guidelines will update soon.
I don't know if I have hope for the guidelines updating soon. I would definitely, so we're starting to get some really good landmark trials, and I think those have the strongest data. They have the biggest patient populations. They're the ones most commonly being cited. So yeah, I'd really look to like the Oviva trial and the POET trial and the upcoming the rodeo trial as well. I think those are kind of your best bet for evidence. If anything, I think, the switch is probably easier than starting on orals, but yeah, just kind of citing the duration. I think the average duration in all of these trials is like, hey, on average, it's about 7 to 10 days of initial IV and then switch, and there's been good outcomes. I think that, I think that would be a good way to go about it if they want more than just one big trial to go off of.
And kind of along those same lines, I guess I have a question with you having an interest in immunocompromised patients. A lot of times they're excluded from trials like this. Do you feel like it can be extrapolated to that patient population?
I think it really depends. I think it definitely, obviously, will depend on like the severity of how immunocompromised they are, risk factors, all of that. I think that will have to be on a case-by-case basis. But I think in some cases, potentially, I think that would be, it would be appropriate to extrapolate in, some more mild, maybe immunocompromised patients. But I think that would be a tougher sell for switching, and whether that's appropriate and what the patient looks like, if they're clinically stable, things like that.
Great. And last call for any more questions. As Julie said, the CE code is there on the screen for you to use in order to get your CE credit.